Hello, my name is Todd David. I'd like to welcome everybody to this Friends of Noe Valley meeting. This is a wonderful turnout, and we're very, very excited to have an amazing group here to talk about universal health care. I really want to thank Molly and Hunter for helping organize this. It's an amazing event, and we're Friends of Noe Valley is proud to be sponsoring this.
So I'm Hunter Stern. I'm the president of the Noe Valley Democratic Club. We are not sponsoring this event, but we were very happy to lend Molly and her expertise to help put it together. And she'll have a moment or two, a few words in a moment or two. I want to plug a couple of our events. And Todd was gracious enough to give me some time. We have our summer, we call this a summer celebration. Basically it's a party. It's next month. It's Thursday, August the 8th. And we have it in a new location this year. It's going to be at Savore's in that garden area. We invite local political bigwigs. But this year we actually have, and Todd mentioned it, the Noe Valley Square gained approval from everybody, which is hard to do in this city. Yes, exactly right.
Putting this program together was like herding cats and then some. These people are very dedicated and very hardworking, and it was really hard to get a hold of them, but we did it, and I think it's going to be a really impressive. They're a very impressive panel, both by their credentials and their dedication to health and human services, so I think it's going to be a marvelous panel. We're going to start with Bonnie for our overview. Bonnie Preston.
I am happy to be here today with you all and with my colleagues here. I'm going to present what the Affordable Care Act is today, what we've accomplished already and where we're going, and then my colleagues will add from more an academic view where they think we're headed. So I hope tonight, from what I say, to explain the basic, that you understand more about the basics of the Affordable Care Act, and you learn about the new health care coverage options soon to be available. And hopefully tonight you'll be inspired to help get people you know who need health insurance, help get them enrolled, because you could improve their health. You could help save a family or a business from financial ruin. And you could also help improve our country's economic future by helping us get more people enrolled. So I want to tell you a little bit about my office, because we'd like to help you in this venture. Health and Human Services in Washington is under Secretary Sebelius, and she has operational departments that do all sorts of different things, like the CDC, is Centers for Disease Control, NIH, the Centers for Medicaid and Medicare, but she also has 10 regional offices, and to represent her and the programs of Health and Human Services in that region. So our region is also contains the states of Nevada, Arizona, Hawaii, and the Pacific Islands, including Hawaii and the Pacific Territories. And we're housed in San Francisco. So San Francisco actually is the home of Region 9. And next slide. Our office tries, so we can next slide. We serve as a public interface for these federal programs. So if you have issues with federal programs and you can't get answers, call us up and we'll triage your question to hopefully get it answered. And we also try to represent regional issues to Washington to try and get regulations tweaked so that the programs work better in our region. And finally, we try to share best practices, things that work well in California often is the case. We try to share that and improve care across the region. So that's what we do. Right now, we have a big focus on implementing the Affordable Care Act, which is now the law of the land after many bumps and turns. We're trying to improve the care that's delivered by focusing the care that federal programs provide and federal programs pay for by stressing patient-centered care and better coordination of care. And then trying to improve the quality of care through changing the way we pay for care to focus more on outcomes than on units of service. Tonight, you're going to hear a lot about better insurance options, because that's what a lot of people are interested in, and a big effort in the bill to improve the accessibility to healthcare and the affordability of healthcare. And finally, a big push in the bill is on keeping people healthy. Large investments were made through the Prevention and Public Health Fund to rebuild and ginny up the public health infrastructure in this country, which has been withered away through lack of funding in the last 20, 30 years. So these are the three aims of the bill. It's not just about coverage. So what's happened so far in our three aims? How have we done? Well, already 54 million Americans receive preventive care without out-of-pocket charges, and this has meant more than 6 million in California have benefited from that, and over 3 million young adults under the age of 26 are now covered, and that has meant 435,000 in California. We've increased funding of community health centers, which in turn have been able to increase the total of number of patients they've served to over 3 million, and also 360,000 small employers have received tax credits to help them purchase insurance for their employees. So other things that have changed, Medi-Cal primary care payment bump. This is something that in California we're still working to get the benefit to the providers, but in the bill, primary care providers are to be paid at Medicare rates, which we hope will increase participation in the Medi-Cal program. So these rates will be retroactive to last, I think it was to last January, when they're eventually in place. And so we hope going forward then that we'll get more provider participation in the Medi-Cal program. And there's been strict anti-fraud measures implemented in Medicare, and since this has started in 2010, this program where there's a lot better coordination between law enforcement and Health and Human Services, and they've been able to crack down on Medicare fraud to the tune of $10.7 billion returned to the Medicare Trust Fund, which has actually extended the Medicare program out at least 8 years. So that's a huge benefit to the program. Also, health insurance companies have paid rebates worth $1.1 billion to nearly 13 million consumers at an average rebate of $151 per household. And I don't know if any of you benefited for this, but every August, insurers have to say that they've spent at least 80% of your premium on medical services, and if not, then they send you a rebate that they've overcharged you for administrative, overhead, marketing, all these other things that are over the limit they're now supposed to spend, allowed to spend on those kinds of non-medical costs. So next, condition denials for children, no more lifetime dollar limits on coverage, insurance companies can't drop your coverage when you get sick, and no more coverage denials without appeal. All these have already been in place. Okay, but the big change is still to come in January of 2014, when there are more new coverage options going to be available to Americans across the country. So since we're in I'm just going to talk about what's happening in California. So based on your income, there will be these new coverage options available. The Medi-Cal program has been expanded by Governor Brown up to limits in the state where if you're a family of 4 and you have an income of $31,000 or less, then you'll be eligible for the Medi-Cal program. And then if your income is higher than that, then there's a new healthcare marketplace called Covered California, where you'll be able, and if you're uninsured and you have an income, if you're a family of four of over $31,000, you'll be able to shop on this new marketplace where you might be eligible for tax credits based on your income to bring those premiums down lower, so it's even more affordable. So those tax credits will be available up to these income limits on the slide. So for a family of four, up to $92,000 for a family of four. If your income falls in there, then you'll be able to benefit from tax credits that will bring the cost of your premiums down. And we can get more into the weeds on this later. And if your income is above these tax credit limits, you'll still be, and you don't have insurance, you'll still be able to shop on the exchange and benefit from the marketplace's negotiated rates. So that's what's coming in January. Okay. So we're anticipating that nationwide that 30 million more, that there would be 30 million more insured people by 2014, and this would be 92% of the non-elderly population, and that's based on the number of people who meet those eligibility requirements that I just talked about. And then for California, they're talking about, sometimes it's 4 million, sometimes it's 5 million. I think Dr. Byron can correct this if I'm wrong. But the estimates, conservative estimate is more than 4 million uninsured in California, insured in California by 2014, with the potential of more than 2 million covered via the new California marketplace, Covered California, and the rest perhaps on Medi-Cal. So on this new marketplace, Covered California, it's basically a website and and a structure for, and it's a marketplace where there are more rules for insurers so that it's going to make it, it's going to bring down costs and make it easier for consumers to find and purchase insurance. So it's an easier way to shop for health insurance. It's going to simplify the search. All your options will be in one place, one application, one time. Individual or family can explore every qualified insurance plan in your area. Most people will be able to get a break on costs, and there will be clear options where you can really tell what these different insurance plans are offering. So we can get into that more too. These plans, the Affordable Care Act lays out required categories of services that all the plans need to offer, and Covered California has taken this a step further and said for the first year they're having one standard benefit package. So Covered California went out to the insurers, the individual insurance market, and they said, okay, we want you to bid on this set of services for plans. And they were able to negotiate based on their estimates of how many people are going to participate in these plans and get really good rates that will be that were announced 2 weeks ago, but they have to go through and get finalized. Though that standard benefit package had to include all these 10 categories of services, and it's a very rich package. And what's different than many that you see on in the individual market is the mental health, substance abuse benefit. Often you won't see that in private insurance. And then also rehabilitative and habilitative services, another area. These are kind of new requirements that make for a strong benefit package. Okay. Also, I indicated that Medi-Cal is expanding to bring in more people, and it not only will it qualify people at a higher income, but it also simplifies the way that people's income are determined. So if you know of people who need health care and they're low income and they didn't qualify before, they should definitely check after October 1st because there's a new eligibility procedure that's much more simple and just basically wants to know that you're low income and you need the coverage. So I think Medi-Cal is really changing. Okay. So getting America covered, it begins now, it all begins with you. We want you to know that come October 1st, open enrollment will begin at Covered California. And the benefits will take effect on January 1st. So it's all coming up very soon. So we're hoping that you can join our national campaign for coverage and if you're interested, you can get important updates through signing up at healthcare.gov, which is the national website for the Affordable Care Act. But if you're interested in helping someone get health insurance or you're interested in getting health insurance yourself in California, please go to coveredca.com and look at what the types of plans that you'll see that you can actually start signing up for on October 1st. Because they already have up on the site a calculator where you can put in your income and you can see what kind of subsidies you would qualify for, and then the different plans that might fit your budget or your friend's budget. So feel free, I have cards here, I'd love to be in touch. So here's my information and I look forward to a good discussion.
Anyway, I do want to say that what Bonnie's talking about is a really big deal, and it's an especially big deal here in California. California is going to be the state that will have the largest number of uninsured people who will gain coverage in relationship to health reform. So we are an extremely significant state with regard to the potential success of this legislation. I saw it was an interesting number when Bonnie put up that in California already something like 425,000 young adults have been covered because of changes already related to the law. So dependent children up to the age of 26 can now be covered under their parents' insurance, and that was about 425,000 people in this state. That's as many people as gained health insurance coverage in all of Massachusetts through their version of the Affordable Care Act, right? So Massachusetts, which I'm going to talk more about, had this tremendous expansion and has sort of been seen as the lead state for what the Affordable Care Act is about, but they have only covered pretty much as many people as we've already covered in our state through this one aspect of the Affordable Care Act. So we are going to be, when we expand, it's going to be 10 times the number of people who gain coverage that Massachusetts did. So it is a very big deal here in California. I also want to just emphasize a couple of things that are really significant that Bonnie touched on with regard to these, what are called now marketplaces, or what had previously been called exchanges. Some people have referred to these as kind of a farmer's market to be able to buy health insurance. It's kind of like when you go either here in Noe Valley or the Ferry Building and so forth, and there's 2 or 3, 4 people selling peaches right next to each other, and you're able to go and taste them and get a feel for, gee, what's the relative cost of these, and I want to, make my value choice about, how much I'm going to spend on it and what I'm going to get. But it's made that very difficult up until this point, and what will really change in a significant way in the Affordable Care Act is that if you were an individual trying to buy insurance today, there's lots of different prices out there and different products and so forth, but it's very hard for you to compare them because the essence of what they're covering is so different that it's very hard for you to know, well, is this a good deal or is that one? One of the really significant things that's happening through these marketplaces is that there's a standardization of what you're buying. And this will take the form of, you will recognize this from the Olympics, of kind of bronze plans, silver plans, gold plans, and platinum plans. And this is really important because you can sort of say, okay, all the bronze plans, which are going to cover on average 60% of your healthcare costs, will be the same. And so that if you see different prices from different insurers, you're going to be able to know and be able to make a value judgment about which one you're going to be able to buy. And this contributes substantially toward how the health insurers then are going to compete much more aggressively with each other to bring down their prices. Just like at the farmer's market, if the peach salesman sees that another farmer next to him is selling the same looking peaches for $1 less a pound, guess what? He's going to adjust his prices and so forth. And I don't know how many of you may have seen today in the New York Times, there was a lead article on the front page about New York's marketplace, just like what was described here by Bonnie in California's, where, lo and behold, when you make real competition, all of a sudden the insurers find that there are ways that they can lower their costs significantly. And the New York Times today reported that there's probably about a 50% reduction in what is going to be charged for these individual insurance products in New York. And we're going to see very substantial reductions as well through the exchange here. So the Affordable Care Act has really structured much more meaningful competition in the health insurance marketplace. And that's a really big deal. Now, I also want to make sure you all understand that if you currently get insurance through your employer, you're likely still to get it that way. You're not going to be doing some of the things that Bonnie described of going to the marketplace or getting Medi-Cal or things like that. That's terrific. In fact, as I'm going to touch on in a moment, when we look at examples of places that have done things like what we're going to have here, again like Massachusetts, what you find is, for the most part, people who are getting insurance through employers continue to get insurance through employers. That's not going to change. What Bonnie was talking about in terms of the new ways to get insurance are really for people who are currently uninsured. And many of those people are individuals who aren't getting insurance through their employer. The other thing I want to emphasize about what Bonnie was bringing up, and I think her pictorial showed it really well, that based on your income level, if you're currently uninsured, you're basically going to be eligible for one or the other. That is, if you're in the lowest income group, up to 138% of the federal poverty level, Medi-Cal is going to be the option for you. You don't get to decide, oh, I want to go into the exchange and get these credits that the federal government will offer to help me buy insurance. Medi-Cal is your option. On the other hand, if you're between 138% and 400%, that's when the federal government will offer some subsidies to help you buy insurance through the exchange. So sometimes people get confused and say, oh, do I get to go to Medi-Cal or do I get to go to the marketplace or the exchange? It's going to be one or the other. However, you don't necessarily need to know the answer ahead of time. It'll be a single application process, and through that application, you will get the answer of, oh, you're eligible for Medi-Cal. You don't have to pay anything else. Or, well, you do have to buy insurance through the exchange, but you're going to get a subsidy to help you do that, and here's how much you're going to get depending on your income level. So I just want to kind of make sure that those issues are understood. Now I want to transition a little bit and talk about why is this such a big deal? What is the benefits related to getting so many more of all of us covered under health insurance coverage? And I think there are at least 2 states that provide some really valuable lessons to us. I've referenced already that Massachusetts in 2006, under a guy named Governor Romney at the time, I think was his name, passed this thing that looks remarkably like the Affordable Care Act, although he apparently forgot about it. In any case, I want to sort of tell you some of the things that have been learned from Massachusetts, because although it's not a carbon copy, the same thing of what the Affordable Care Act is, there are many, many parallels to how it's structured. And so there are, I think, some valuable lessons about what's going on there and what we might anticipate here in California. So one is, one question you can ask is, okay, does the law get more people covered? Do in fact more people end up getting health insurance? And in fact, in Massachusetts, which was already a state that had a pretty high level of health insurance, higher than what we're starting off here in California. On average, across the country, about 18% of individuals are uninsured below the age of 65. In Massachusetts, they were starting off with only about 10% of their population uninsured. Well, by the time they put this law in place in Massachusetts, they got their uninsured rate down to about 4 to 5%. So they cut it in half, pretty significant. Second question is, okay, it's wonderful people get coverage, but isn't the whole point of coverage to get access to health care? And in fact, they looked into that as well, and if you looked at statewide statistics in Massachusetts, prior to their law changing, about 85% of their population reported that they have a regular place to go for care. After the law passed, that was up to about 91% of their population. So clearly getting health insurance coverage expanded did help more people get access to care. It also, health insurance is fundamentally a financial product, and so one of the questions is, does it in fact protect people's finances? And what was seen in Massachusetts is that people who reported that they had unmet medical needs reduced from about 16% of the population in Massachusetts down to about 11 or 12%. So it did serve the purpose of making a larger portion of their population have greater financial coverage. And in fact, among low-income people, it was actually a much more dramatic increase because, of course, low-income individuals were the ones who were particularly at risk for having financial problems and paying out of pocket and so forth. So there were even bigger reductions there. And there were all sorts of other benefits associated with it, like preventive health care needs, things like getting immunizations, getting checkups, and other kinds of screenings like mammography and pap smears and colon screening and so forth for cancer were dramatically increased from about 70% of their population in Massachusetts up closer to 80% of their population. So pretty big increases in the use of preventive care. There were recognized disparities in healthcare based on race and ethnicity in Massachusetts before this law was in place. They didn't completely eliminate them in the state, but the gaps did shrink significantly, again, because of many of the people who gained insurance coverage did come from underrepresented minority groups. There's some interesting work I saw at a conference just about a month or so ago in which researchers in Massachusetts also have looked at things like mortality rates among low-income people in Massachusetts and have actually seen a significant reduction in mortality rates that suggests that there are health outcome benefits associated with health insurance expansion in Massachusetts as well. Then some people sometimes ask a little about, well, what about where did people go for coverage and what happened to the safety net? Sometimes people wonder, well, if we're all going to be covered under health insurance, maybe we don't need the safety net anymore. Places like San Francisco General where I work and so forth. One of the interesting things there is that in Massachusetts, if you looked at where the big surge was of where people got care after coverage, in fact, most of that surge happened in places like community health centers and in some of their safety net hospitals. Those places saw about a 12% increase in care after their law was passed. So I would actually suspect that places like San Francisco General Hospital are in fact going to remain very significant and important places where people are going to go for care. One of the things that tends to happen is that many of the people who are uninsured who gain coverage in fact have been saving up a lot of unmet need that they've put off paying for things out of pocket and have walked around with kind of a painful hip. I mean, obviously you can't put off things that are life and death. If you're in the middle of a heart attack, that's no time to say, I'll deal with it tomorrow. Clearly you can't do that. But if you have a painful hip that could really benefit from a hip replacement or other things like that, people do put these things off because, in fact, of financial need. And so we will expect to see some surge in utilization related to coverage, even though we're in a community like San Francisco that has a fantastic safety net already in place for the uninsured through programs like our Healthy San Francisco program and so forth. But I still would expect to see some increase in use of services at the safety net. And I think it's really important that our safety net survive here as well, because something that Bonnie touched on, which is that, in fact, some of the individuals living amongst us are in fact not going to be able to gain coverage under the Affordable Care Act. One of the things that the Act does not cover is expansion of insurance coverage to people who are not citizens of the United States. And so as a result, there is going to be still among us many who will not be able to gain coverage under this law. And likely, the kinds of places where they were going to need to continue to go for care will be some of our community health centers and San Francisco General Hospital and so forth. So the safety net will remain really as one of the few places where these individuals will be able to continue to get care for basic health care needs. One other issue I want to touch on in Massachusetts is some people have wondered, and I touched on this in the beginning, whether this expansion of government coverage for the uninsured, does it in fact somehow cannibalize the insurance programs already made available through our employers? And interestingly, if you look in Massachusetts, that didn't happen. In fact, if anything, what you saw in Massachusetts is that more employers actually stepped up to start offering health insurance benefits to their employees. And that's because, in fact, it goes back to the heart probably of why employers started offering insurance to employees in the first place, which is to build loyalty and a connection with their employees to, in fact, have them want to continue to work at their company for years to come and to retain good employees. And in Massachusetts, what you see is, in fact, coverage through employment actually went up some. It was not undermined by the law in Massachusetts. I also want to just touch a little bit on, there's been another example that I think is also helpful to look at, and I made a paper of this, and I think Molly may have passed it around. You're welcome to take a look at it. I won't, it's a relatively short article that I was involved in writing, but the state of Oregon had a randomized expansion of their Medicaid program a few years ago, and there's been an opportunity to evaluate what impact the expansion of Medicaid has offered in the state of Oregon, which gives lessons as well for what's going to happen in California and other states as we expand our Medicaid programs. And again, what you see in Oregon is that it did have a dramatic impact on improving access to care for people. So you may have actually read press articles that some people have said Medicaid's a broken program. Why would we expand coverage through the Medicaid program? And if you look at what's gone on in Oregon, actually Medicaid expansion is very significant in terms of improving people's access to care and getting them a regular provider, getting them preventive care, and giving them financial protection. I'm going to look forward to answering some of your questions when we get to the question and answer period, but I do just want to kind of have you think a little bit about some of the challenges that I see in California as we move toward expansion of coverage. One is that many of the uninsured in this state are individuals who have limited English proficiency. And so there's going to be some real challenges about how we can, in fact, get the word out. Meetings like this, which are fantastic to see the kind of the number of people coming out in Noe Valley to learn about this, but we need meetings like this and outreach to happen all across the state so that those who are at high risk know about the opportunity there. It isn't enough just to be eligible. People have to step up and get enrolled, or else it's not going to be the successful program that it can be. So we need to, in fact, have successful strategies to reach people in multiple languages and in different ways through their communities to know to sign up. Second is that you may have read about that there's a doctor shortage and so forth. And in reality, we actually have a pretty good number of doctors in this country for the size of our population, but what we have is a mismatch, a tremendous mismatch between where the greatest needs are and where the doctors happen to practice. And in the case of looking at where expansion is going to happen for the uninsured, there's a very dramatic mismatch that where we're going to see the biggest growth in the number of uninsured. In our state, the largest numbers of uninsured are actually in the Central Valley and in Southern California, and in those same locations you can look, that's the places where we have the greatest limitations of where doctors and other kinds of health providers are. And we're going to need to figure out solutions of how we can, in fact, either encourage doctors to work in those areas or to expand the opportunities for other kinds of health professionals, nurse practitioners, physician assistants, and others to be part of filling this access gap. It's going to be a very significant issue that the expansion will happen in many of the places where we don't have providers available. And this could cause some tension in the system of turning, again, coverage into access. So I really look forward to addressing some of the questions you may have about this, but thank you very much for having me here tonight, even on a foggy night.
I'm Ellen Schaefer, for those of you who came in late, co-director of the Center for Policy Analysis. We sponsor the Equal Health Network and the Trust Women, the Silver Ribbon Campaign to Trust Women. I'm going to talk about both of those campaigns in talking about healthcare reform. A couple things I want to say up front, and echoing the final remarks of Dr. Beinman, I really want to thank Molly and Todd and Hunter and all of you for coming out. There's really just a dearth of these kinds of meetings here in San Francisco and around the state to let people know about these issues. And I think, as you'll see from my discussion, I think it's really important that we get the word out about this historic program, and also that we remain politically active in our community. So I'm very excited for all those reasons to be here. My coat is acrylic. And I have a paper in the back, the one that Molly mentioned to you, that describes in a little bit more detail what the outline is of the Affordable Care Act and discusses some of the political pros and cons. So, I'm going to say some critical things about the Affordable Care Act and talk a little bit more about the things that we didn't get accomplished. But I want to say, it was a big deal. A lot of us worked on this. It was a historic victory, and I think we can give ourselves a hand. So, thank you.
Single payer.
Single payer, we need to talk about that too, for sure. Cost control is something we're going to have to work on, and I've been at that, as many of you have, for, I don't know, 15 or 16 decades, I don't know, but this is getting us there. So certainly coverage and affordability are incomplete. As we've heard, immigrants, the exclusion of immigrants, undocumented workers here from the plan is a big problem. More here in California than, can people see? I've been in some other places. And I'm going to talk quite a bit about reproductive health care because contraception, as there have been questions about covering contraception as a preventive health care benefit, believe it or not, although we managed to accomplish that. Abortion care is not covered through it's not subsidized through the exchanges. So I want to talk about that some too. But first of all, I want to talk about just the general political environment that we find ourselves in, which is not necessarily related to the problems that I mentioned. The House has been voting on a pretty regular basis to repeal the entire law. It was today. Pardon?
They did it again
today.
today.
They did it again today, right. Well, there's no other problems that they might want to think about. So, and as we know, it was challenged legally in the Supreme Court. The decision, June 2012, gave us the program that we have now. So why is this controversial? And I'm not going to talk too much about the healthcare system and the trillions of dollars that we spend every year on the industry, but more about the situation that we find ourselves in politically and economically. As probably a lot of you know, between 1979 and now we've seen a shift in the economy, the withering away of the middle class, and a real explosion in economic inequality. The top 1% have most of their control most of the wealth and have most of their wealth in business and financial securities. The bottom 1% hold most of our wealth in homes, and the value of those tanked significantly over the last few years, and it's created a real crisis in the country. We're facing austerity hysteria, which targets long-standing benefits that many of us depend on. There have been proposals for something called a chain CPI, an attempt to cut important social benefit programs, Social Security, and also Medicare. The House just passed a farm bill. This is from Gail Collins' column in the New York Times the other day. Just passed a farm bill that keeps subsidies for agriculture and cuts the food stamp program. Stephen Fincher, a representative from Tennessee, was complaining about people who aren't willing to work shall not eat. He's received $3.5 million in federal agricultural subsidies for cotton. In addition, there are assaults both at the federal and state level on access to abortion, and this continues through the first half of 2013. It's been going on since 2010 in a serious concerted way. So we can say that there are the opposition to the Affordable Care Act, as well as these other policies, represents competing visions. The sense that government policies are distorting the healthcare market, that we should get rid of Obamacare, put consumers in charge, as opposed to thinking, you know, we need to use the power of the government and resources that are essential to ensure access based on need as opposed to income, to negotiate prices and balance the power of the pharmaceutical and drug and for-profit hospital and et cetera industries, and to initiate a payment system reforms to improve quality. So we could look at it that way. Another way to say it, there's a fierce medieval patriarchy financed by corporations versus our American values of democracy, independence, fairness, progress, and innovation. So let's talk about, I'm going to talk a little bit about the situation of immigrants and who's not covered and why that's important, and then talk about reproductive health care. Universal coverage, which we are moving towards in a deliberate fashion, although not as quickly as some of us and completely as we would like to. Universal coverage is an important human right. Preventive care improves health, reduces emergency room use. Undocumented people pay a lot in taxes, do pay for health care, and don't get the benefits that they pay for. There are disparities in the uninsured. Based on race, 32% of Latinos are uninsured, 20% of blacks, and 13% of whites. So how are immigrants treated, under the Affordable Care Act? As you've heard, legal immigrants have to wait longer for coverage under certain federal programs than American citizens, but do get some coverage. Undocumented workers and undocumented residents are not covered through the exchanges. They can apply for tax credits or for Medi-Cal. Community health centers and hospitals still must stabilize people who present with emergency situations. And this is just showing, as you might expect, that insurance status goes down by, insurance coverage goes down by residents, by naturalization status. Of course, most undocumented people do work, so some people do get coverage through the workplace at the moment. This is a particular issue, again, for us in California. We're the home to more unauthorized residents than any other state. Now, moving on to the subject of reproductive rights. These are a couple of people around my age. They're saying, I can't believe I still have to protest this stuff. So, a lot of good news for women in the Affordable Care Act. It used to be the case that insurance companies could charge us more just for being women. It used to be that insurance companies could drop you from coverage even after you had it because you needed it, because you were sick, including for conditions such as pregnancy. It prevents the need for, there's great coverage for preventive services. You don't need a prior authorization, for example, for obstetric and gynecological care. Starting in August of last year, there was a great expansion of preventive services available without co-pays and deductibles, including, again, after 3 years of federal investigations as to whether contraception is indeed a preventive health care benefit. They decided it was, so we're pretty much covered for that. Except if you work for a religiously based employer. So if you work for a church or a church-affiliated hospital, university, or charity, or other kind of school, it's a little different depending on which it is. But your employer basically has a say in whether or not you get this coverage. If it's a church, you don't. If it's another kind of religiously affiliated employer, you do, but you have to squiggle around. So the question is, in a situation where most heterosexually active people in this country use or have used contraception, where most of the employees at these employers don't share either the belief or the religious affiliation of their employer, why does the employer have a right to determine what benefits their employees are going to have access to in this very important realm of health? Abortion, as I said, we've had the Hyde Act, the Hyde Amendment since 1976 in the United States that precludes federal funds from being used for abortion services. We have found ways here in California to make those services available through Medi-Cal, which again, as you picked up, is the federal state program for low-income people. We have found ways to cover it both in San Francisco through Healthy San Francisco and other programs, and also through Medi-Cal. However, the exclusion, the compromise that was forced to make possible the passage of the Affordable Care Act is requiring some very difficult sort of maneuvering by women and by insurers in order to get this benefit, even if they're in a private plan. And this is just showing both the sharp rise in attacks on abortion care at the state level, and you probably can't see this, but the change in unintended pregnancies by income level. So the point of this is just that probably most of us in this room can get contraception. We probably haven't had a high rate of unintended pregnancies. Contraception does fail, it does happen, but it's going up tremendously among lower income women, and that is really because of lack of access. 30% of women have had an abortion. Most people think, as you'll see in a subsequent slide, believe that it should be legal. 52% it should be legal under certain circumstances, 26% under any circumstance, and only 20% illegal under any circumstance. Women vote based on support for abortion. Saying the word abortion has made a difference in the most recent election. Top reasons to support Obama among unmarried women who voted in the last election was support for Planned Parenthood, preventive health care, and pay equity for women. The top reason not to vote for Romney among unmarried women was that being against those very policies. We are seeing a rash of anti-choice provisions and right-wing politics. As of June 16th, state legislators have introduced more than 300 different abortion restrictions just in the first part of this year, requiring ultrasounds, requiring standards that require abortion clinics to meet the same standards as surgery centers, that require rebuilding and restructuring, nothing to do with quality of care. The House of Representatives has passed the Pain-Capable Unborn Child Protection Act. Did people watch Wendy Davis? You saw what was going on in Texas, where State Senator Wendy Davis heroically filibustered for 11 hours on the floor of the state Senate, and most importantly, I think, called up the people of Texas to show up there and really put off the vote. Rick Perry, who we have the good news, I know this is a nonpartisan setting, but we hear he's not going to run again for office at the end of this term. However, he has pushed through the measure that she heroically and that the people heroically opposed. Ohio, North Dakota, North Carolina are all pursuing these policies. These are states that have recently, and I think it's up to the minute, been passing these kinds of restrictions. It is possible that a case may be going to the Supreme Court, and that may be part of the strategy. So, briefly, I hope, I want to talk just quickly about the Trust Women Silver Ribbon Campaign. We have pins in the back of the room that say Trust Women, because we believe that it's important to trust women with health decisions that affect our lives. We legitimize and celebrate women's reproductive health, including abortion, as vital to the social and economic health of our communities. respect and honor gender equality and women's self-determination, and affirm our social connectedness. We're a coalition of partners. Our website is really encouraging organizations to come together. We collect money for ourselves for the pins. We let our partners collect money as well. We've specifically set it up that way. We have celebrated the anniversary of the Roe versus Wade decision, the Supreme Court decision that legalized abortion in 1973. We encourage folks to wear the pins. We've had banners on Market Street talking about our symbol, the silver ribbon symbol, and also including banners from Planned Parenthood and other organizations with slogans talking about the importance of choice. This is one of the banners flying at City Hall, January 2012. We're starting an open petition system. I know everybody's used to going online and clicking, and you kind of wonder where those petitions go. We're encouraging organizations to sponsor petitions and statements of support collaboratively, and setting up a system that allows them to build their membership lists. So learning from Texas challenges and opportunities, we think it's important to build public awareness, certainly about the Affordable Care Act, about improvements to health care that we all need, but to draw links between and among these different issues, to really fight to make sure that we do get the coverage that we need, that we talk about the importance of making sure that health care is affordable, making sure that the people in our community who are here and working and are not documented get the coverage that they need to oppose divisive policies that make it difficult to pursue those kinds of policies that benefit us. Just a note, I thought a few people here might be in my age group. This issue of reproductive rights is something that speaks to us in a particular way, and I want to encourage those of us who lived through watching girls disappear from high school, watching people not come back from abortions in Mexico or other illegal abortions, that we remember what that was like and pick up the role and become active and involved. So on the Affordable Care Act, I think we have to continue to inform ourselves, make sure, as we've been asked to do, that the word gets around to people who really need this benefit, make sure that we continue to look forward to improving it, and encourage you to sign up for our listservs, stay in touch with each other, and have a discussion. So thank you very much.